Hello friends, welcome to this session of recall for NEET PG 2023 Biochemistry. As we had discussed previously, largest number of questions came from the vitamins, and this was very much expected. For the last 2 years, we are seeing more and more questions coming from vitamins. Besides vitamins, another focus was the inborn errors of metabolism. Again, this was very expected. When we highlighted the points that you need to cover before the exam, we had specifically mentioned the different types of inborn error of metabolism which you need to cover. So these are the two main topics which are covered in the NEET PG 2023 from Biochemistry. Surprisingly, a total of 22 questions were there out of 200 from Biochemistry. I in fact left out 4 questions which were overlap with other subjects like physiology, etc. But still we are left with 22 questions which were asked. A lot of questions look to be the same question being slightly modified and being asked, particularly from the vitamins. Same vitamin being asked twice or even thrice in some cases. So let's quickly cover the points which were asked in this exam. Okay, so question number 1. Patient consuming predominantly polished rice presents with cardiomegaly and pleural effusion. Match the vitamin deficiency in this patient with the correct investigation. So you can see this is a two-part question. Your options were riboflavin with glutathione reductase, pyridoxine with xanthorronic acid, riboflavin with transketolase, and thiamine with transketolase. So this is a two-part question. First, you have to identify the type of vitamin deficiency based on the clinical presentation, right? So clinical presentation says cardiomegaly with pleural effusion, and the leading cause is polished rice. Now, when the polished rice is consumed in comparison to the brown rice, the bran part which is removed, it contains lots of vitamins and minerals. The most important one which is being lost in this case is the vitamin B1. So we are looking at the deficiency of thiamine. All right, we are looking at the deficiency of thiamine, and all of you know the thiamine deficiency can be identified by measuring the activity of the erythrocyte transketolase. So we have to look at the activity of erythrocyte transketolase after it is supplemented with the thiamine, and the correct answer should be thiamine deficiency, which is identified by measuring the activity of erythrocyte transketolase. You should also remember for riboflavin, the glutathione reductase is used to identify the activity. This is the correct statement for riboflavin, but in this case, the deficiency for riboflavin is not there. Okay, in this case, the deficiency for thiamine is there. Okay, similarly for pyridoxine in the urine, you can see the xanthorronic acid in the urine. So this statement is also correct, but again, we are not looking at deficiency of pyridoxine. Riboflavin with transketolase is wrong. Thiamine with transketolase is correct, and particularly in this case, we are looking at the deficiency of vitamin B1. That is the thiamine. We'll see a lot of questions from thiamine have been asked. In fact, the next question is also on thiamine only. Let's see. A patient is found to have atrophied mammillary bodies and presents with confusion and nystagmus. Likely diagnosis is this confusion and nystagmus is characteristic of what is known as Wernicke's encephalopathy. Okay, so here the answer should be the Wernicke's encephalopathy. The atrophied mammillary bodies may also be seen in Lake disease, in central venous thrombosis, but there the confusion, nystagmus, etc. may not be there. So this confusion, nystagmus along with atrophied mammillary bodies, your diagnosis should be Wernicke's encephalopathy. Wernicke's encephalopathy and beriberi. These are the two very important conditions associated with the vitamin B1, that is thiamine deficiency. This is again a case of thiamine deficiency. All right, this is again a case of thiamine deficiency where we can have the beriberi and Wernicke's encephalopathy. The encephalopathy may sometimes be associated with the psychosis. When it is associated with psychosis, we call it Wernicke's Korsakoff psychosis. Okay, so this is the last name which you remember in this case. First beriberi, second is Wernicke encephalopathy, and third is Wernicke-Korsakoff psychosis. And another question, patient is brought to emergency with confusion, ataxia and ophthalmoplegia. Likely deficiency in this patient is for which of the vitamins? So in this case, again you see confusion, ataxia, ophthalmoplegia, we are looking at the Wernicke's. right? We are looking at wernicase, and wernicase is due to the deficiency of vitamin B1, that is thiamine. So you see, three different questions coming from one vitamin. Very, very important. Vitamins are by far the most commonly asked question nowadays, keeping in mind the widespread malnutrition that we are seeing in the population. All right, whether it is over nutrition or undernutrition, most of the patients have some sort of vitamin deficiency. So the questions on vitamins have become much more frequent. All right, moving on to next question. A child presents with dementia, diarrhea, and dermatitis. This is the classical 3Ds that we talk about. Which of the following is the suspected deficiency? Your options are ascorbic acid, niacin, thiamine, cobalamin. Now, when the 3Ds are there, immediately in your mind, the name which has to come is the pellagra. And you know, pellagra is due to the deficiency of the vitamin B3, that is the niacin. All right, though, so in this case we have the niacin, which is deficient. Niacin is formed from the tryptophan. 60 milligram of tryptophan is used to make 1 milligram of niacin. A lot of factors which can affect the formation of niacin. Individuals which consume more of maize and sorghum, there also we see that deficiency of the niacin can be there. Then in case of the heart nerves disease, in case of the carcinoid syndrome, in all of these cases you can see the features of pellagra, because the formation of niacin from tryptophan will start getting affected. Another important point in the pellagra which you might see is the Casal collar, also known as the Casal necklace. There is scaly pigmentation of the C3 C4 dermatome in a V shape at the front of the neck, which gives the appearance of the necklace. Okay, so these are the important points with the niacin deficiency. Moving on to next question. A child presents with dermatitis, thinning of hair, and alopecia. The family gives history of eating a raw egg white for a long time. Which vitamin deficiency is likely to be there? Your options are vitamin A, B12, biotin, pyridoxine. Here, what you have to remember, as soon as we say raw egg white, the term which has to come to your mind is avidin. What is the role of avidin? Avidin inhibits the absorption of biotin. However, for it to become effective, for it to present some problem, either the amount of avidin should be large, means you are consuming large amount of the raw egg white, or you should be consuming it for a longer time. So in these cases, what will happen? The biotin absorption will get affected. Biotin will complex with the avidin. It cannot get absorbed. In these patients, biotin deficiency may be there. Remember, biotin is required for the 4 different carboxylases which are there in our body. All right, the carboxylases are very important in gluconeogenesis. So if carboxylases are not there, then weakness, hypoglycemia, these will be some of the presentations in the patient, along with the dermatitis, thinning of hair, alopecia. These are additional findings that we see in the biotin deficiency. So raw egg white, immediately you should remember that avidin is present in the raw egg white. When you heat it, avidin gets inactivated. Therefore, it is not able to bind with the biotin any longer. So if avidin is available, it will complex with biotin and it will inhibit the absorption of biotin. Moving to question number 6, a person presented with neurological manifestation mimicking upper motor neuron palsy and sensory neuropathy. The patient was pale. An investigation revealed anemia. The probable diagnosis is subacute combined degeneration of the cord, SACD, megaloblastic anemia, cranial infarct, and MELAS. MELAS is a mitochondrial disorder. Okay, so here you have to see 2 things. Number 1, there is neuropathy, right? There is neuropathy. Along with neuropathy, there is anemia. The first differential which should come to your mind is the pernicious anemia, right? The pernicious anemia, where there is neurological deficit, and along with that there is a megaloblastic anemia. This we see in case of the B12 deficiency, right? B12 deficiency. Why? Because B12 is required in one of the proteins which causes the activity of the neurons. The deposition of the lipids along the axons is carried out by one of the proteins which requires the vitamin B12. In addition, the B12 deficiency will cause the folate trap. It will cause the folate trap, because of which you will see the patients having the megaloblastic anemia, right? So when B12 deficiency is there, we'll see both the neurological deficit as well as anemia, which is megaloblastic in nature. So megaloblastic anemia is there, but it is not the only part of the presentation. There we also have the neurological deficit. So this results in the subacute combined degeneration. This is due to the B12 deficiency. So best answer here would be SACD, okay, which is due to the B12 deficiency. Moving on to question number 7. A patient presents with petechiae and bleeding gums. He is suspected to be suffering from scurvy. Diagnosis already given. He is suspected to be suffering from scurvy. The biochemical basis of scurvy is... Options are impaired collagen synthesis, increased keratinization of epithelium, inhibiting clotting factors, and low calcium. So you know the role of vitamin C in the development of extracellular matrix, that it is required for hydroxylation of two amino acids, proline and lysine. It is required for hydroxylation of proline and lysine. If vitamin C is not available, hydroxylation of these two amino acids will not take place. The cross-linking, which is normally occurring in the different polypeptides of the collagen, due to this hydroxylation will be affected. Because cross-linking is not taking place, collagen will be weak, it will be friable, it will break very easily. Whenever the little bit of strain is there, it will break very easily. Commonly, this collagen will be present in large amount in the extracellular matrix. So the vessels, the capillaries, they will be weak if the collagen is weak. Therefore, even if slight amount of pressure is there, the blood vessels will break and the bleeding will start. So bleeding around the gums, petechiae, bleeding around the hair follicles, the bleeding around the joints, bleeding around the costochondral junction and the scorbutic rosary. All of these are the prominent features. Even the bruising is very easy in the patients. A slight bit of pressure will be there and the bruising can take place in these patients. So the biochemical basis of scurvy is impaired collagen synthesis, the hydroxylation of proline and lysine by prolyl and lysyl hydroxylase. These are the enzymes which will carry out the hydroxylation, which require the vitamin C. This is what will get affected. Moving on to next question. There is a history of village people consuming a crop as a staple diet. The name of the crop is not mentioned. Many of the villagers are now presenting with paresis and are using a stick to stand. Which of the following vitamins would help? Your options are vitamin A, vitamin D, vitamin C, and vitamin K. Okay, so in this case, when they're giving the hint that okay, one of the vitamins can help, then immediately the condition which should come to your mind is osteolethyrism. Osteolethyrism should immediately come to your mind. The Lathyrus odoratus, subtype of Lathyrus, contains the BAPN, the beta aminopropionitrile. The exact name is gamma glutamyl beta aminopropionitrile, which is responsible for osteolethyrism. Okay, so in osteolethyrism, what happens that the lysyl oxidase activity is getting affected. So the cross-linking, covalent cross-linking between the peptides which occurs in the extracellular matrix is getting affected. When you supplement with vitamin C, what will happen? Additional cross-links which will be non-covalent in nature will take place. So they somewhat compensate for the loss of cross-linking due to the lysyl oxidase. Okay, so that is how the vitamin C can help. The vitamin C can help in patients of osteolethyrism. Along with osteolethyrism, you should also remember the two names, the homoarginine and BOA. In fact, we have a question in this paper itself. The homoarginine and BOA, they are causing the neurolethyrism. they are also obtained from Lathyrus, a different species of the Lathyrus, that is Lathyrus sativus. Here we have Lathyrus odoratus, here we have Lathyrus sativus, which contains the boa and homogeneine. They are responsible for neurolathyrism. Lastly, another Lathyrus species contains the diaminobutyric acid. Okay, this will cause the hepatic damage. It inhibits the hepatic urocycle enzyme ornithine transcarbamylase. Okay, so these are the important, we can say, toxic amino acids coming out from the Lathyrus species. Along with this, one last name which you have to remember, that is the plant Argemone mexicana oil, contains the sanguinarine and dehydrosanguinarine, which is responsible for the epidemic dropsy. This can be a separate question in the next paper. So remember this, the Argemone oil containing the sanguinarine and dehydrosanguinarine responsible for the epidemic dropsy. The Argemone mexicana commonly grows with the mustard plant as a weed. So if the proper weeding is not done, the mustard oil can easily get contaminated with the Argemone oil. Thereby, the sanguinarine and dehydrosanguinarine content in the mustard oil can be significant, which can give rise to the epidemic dropsy. In India, there have been episodes of this epidemic when the precaution has not been taken, and some of the areas have been widely infested with the Argemone mexicana. Okay. Nowadays, slightly less common because of the awareness among the farmers. The proper weeding is being done, and the Argemone mexicana infestation in the mustard fields is very, very less. Okay, image based question. You can see the genoverum is shown here, and you are asked what is the possible cause. You can see the child is there, probably 2 to 3 years old, and in this case the genoverum is there. This is due to the deficiency of vitamin D. We call this the rickets. I'm sure all of you know this, nothing much to tell here. Only thing you should know, what are the other clinical presentations which may be there in a patient of rickets. So this time they have given the genoverum. They can give the other presentations also. So let us quickly see the other important clinical features which you should know in patient of rickets. If you look at the skull, you have delayed closure of fontanelles. The wide sutures are there. The frontal bossing is there. At the back, the craniotabes is there, and the dental hypoplasia is there. So in the skull itself, you can see 5 different findings. Okay. Coming to the chest part, you see the rachitic rosary. Please don't confuse the rachitic rosary with scorbutic rosary. Rachitic rosary is swollen, but it is painless. The scorbutic rosary is swollen, but it is painful. Okay, so this is the rachitic rosary. Along with this, you have the pectus carinatum and the Harrison's sulcus. These 3 you will see in the chest. At the joints of the wrist and the ankle, what do you find? Swelling in wrist and ankle joints. At the ankle level, it may present as an additional malleoli, so we call it the third malleoli. The third malleoli presentation may be seen in patients of rickets. And lastly, the bowing of the legs, depending on the age of the patient. When this rickets is happening, you can have the genoverum or you can have the genovalgum. So inward bowing or outward bowing, depending on the age of the child, can be there. In vitamin D, another question which is commonly asked is the different parts of the body involved in activation of vitamin D. So you should know, number 1, in the skin, the cholesterol converted to the vitamin D3 form under the influence of the UV light. This D3, whether it is coming from the cholesterol or it is coming from diet, is quickly converted into the 25-hydroxycholecalciferol in the liver, and subsequently it is converted into the 125-dihydroxycholecalciferol in the kidney. So skin, liver, kidney, this is the order of involvement of the organs in activation, or you can say metabolism of the vitamin D. Lastly, the inactivation of 125 also occurs in the kidney only. Okay. So there is a sequence of organs, another very important question in vitamin D which you should know. Moving on, all of the followings are vitamin K dependent for activation except, and here your options are factor 2, 5, 9 and 10. Okay, so the vitamin K is responsible for the gamma carboxylation. It is responsible for gamma carboxylation of glutamate, resulting in formation of what is known as the GLA. gamma carboxylated glutamate is called GLA. GLA is very important because it chelates with the calcium. The normal glutamate will not bind with the calcium, but this GLA is able to chelate with the calcium. So in this case, the calcium is now able to act as a bridge. Alright, wherever the aggregation of molecules is required, there the carboxylation of glutamate is very useful. So a lot of proteins will require this carboxylation, where vitamin K will play a very important role. A lot of clotting factors, the anti-clotting factors, the nephrocalcin, the osteocalcin, all of these will require this. Among the clotting factors, the factors which require the carboxylation are 2, 7, 9 and 10. It's not number 5. It's not number 5 which will be your answer. It should be 2, 7, 9 and 10, which require the gamma carboxylation for the activation. Quick points about vitamin K. Like I told you, it is required for the carboxylation of glutamate residue and gives rise to the gamma carboxyglutamate called the GLA. Enzymes involved in this process are the vitamin K epoxide reductase and the quinone reductase. Dicumarol is inhibitor of the epoxide reductase, and the important proteins which require the carboxylation 2, 7, 9 and 10, along with protein C and protein S, which are the anti-clotting factors. The GLA chelates calcium ions. It promotes the binding to the membranes, and deficiency is identified by measuring the undercarboxylated osteocalcin in the blood, because osteocalcin is another protein which requires the carboxylation along with the nephrocalcin in the kidney. Okay, these are additional proteins which require the gamma carboxylation of the glutamate. So you can use the levels of the undercarboxylated osteocalcin to estimate the degree of the vitamin K deficiency. Then we have a 14-month-old child presenting with erythematous, scaly and pustular lesions in the perioral region associated with diarrhea. The parents give history of poor wound healing. The probable mineral deficiency. So see here, multiple things are there. First, let us look at the options. Copper, iron, zinc, iodine. First thing which is given here is the involvement of skin, erythematous, scaly and pustular lesions. Okay, so in this, the skin is getting involved. The diarrhea is also there. These two are characteristic for the acrodermatitis enteropathica. I'm sure all of you know this. The acrodermatitis enteropathica, which is due to the deficiency of zinc, right? So this is a classical case of acrodermatitis enteropathica. Your answer should be zinc. Okay, if only poor wound healing was mentioned, in that case we may think about the copper deficiency. Why? Because copper is required for the activation of lysyl oxidase, which is doing the cross-linking, the covalent cross-linking between the collagen polypeptides. But the more prominent features here are the skin features and the diarrhea. So this is definitely a case of acrodermatitis enteropathica, and we're looking at the zinc deficiency. Okay, so you saw around 11 questions coming from vitamins and minerals, or in fact I would say 10 questions coming from vitamins and 1 question coming from the minerals, and that too zinc. Typically you get a question on zinc, copper and iron. These are the 3 minerals which are commonly asked, but you saw 10 questions coming from the vitamins. Moving on to question 12, a child has severe cramps after exercise and blood sample collected soon after exercise showed low glucose and low lactate levels. The probable diagnosis is. So the options are McArdle's, Von Gerke, Cory's and Pompey's. See here, severe cramps after exercise. Before exercise the presentation is not there. So this means that mainly it is the muscle which is affected, right? It is mainly the muscle which is affected. Obviously some amount of hypoglycemia is definitely there. Low lactate level again indicates that the utilization of the glycogen in the muscle is getting affected. Why? Because when you do the exercise, the muscle glycogen gets metabolized via the anaerobic glycolysis, right? So after exercise, when the anaerobic glycolysis takes place, the lactate level will be high in the blood. But in this case, lactate level is low, meaning the problem is there in the muscle, and that too in the glycogen metabolism. So the muscle phosphorylase the muscle glycogen phosphorylase deficiency is seen in McArdle's. Okay, so this is a case of McArdle's where the myophosphorylase is deficient, and that is why the patient has exercise intolerance. Please note, this is exercise intolerance, and because the muscle glycogen is not getting mobilized, these patients will present with the low lactate levels. High lactate level will be seen after exercise when the muscle glycogen is mobilized, because in this case we will have the anaerobic glycolysis. Muscle glycogen is not mobilized. In that case, you will have the low lactate. Most of the glycogen storage disorders definitely have the hypoglycemia, so that is the common feature among all the different types of the glycogen storage disorders. Going on to next question. A 4-year-old child presents with easy fatigability. The mother gives the history of the child being lethargic in between the meals. The child is much improved after meals. On examination, there is no organomegaly. Please note, there is no organomegaly. Liver biopsy showed no glycogen. Very specifically, I am highlighting, all the students said that mention was no glycogen in liver biopsy. Likely defect is for, your options are the branching enzyme, the debranching enzyme, glucose 6-phosphatase, and the glycogen synthase. If you look at the first 3 options, the branching, debranching, and the glucose 6-phosphatase, in all of them we find increase in glycogen in the liver. So even if you don't know that this is possibly because of glycogen synthase, you can rule out the first 3, and by Occam's razor, whatever is left, no matter how improbable, has to be the answer. If you are eliminating the first 3, because in those cases the liver glycogen is increased, so whatever is left is your answer. In this case, glycogen synthase. Glycogen synthase, if you have looked at the table showing the glycogen storage disorders, is categorized as type 0 of the glycogen storage disorders. Type 0 because of 2 reasons. Number 1, the full-blown case of the deficiency of glycogen synthase patient would not survive. Okay, and secondly, it is called 0 because in this case the glycogen itself will not be formed. Okay, so there is no, the glycogen storage is not happening, but glycogen formation is not happening. Okay, so partial deficiency of glycogen synthase might be there in this patient, because if full-blown deficiency is there, in that case the patient would not survive. The children typically die in utero. Okay, so normally we don't discuss about the deficiency of glycogen synthase, but in this case they have specifically mentioned that liver biopsy does not show any glycogen, so you're left with the answer of the glycogen synthase. Moving to question number 14. A patient presents with childhood black urine syndrome. This all of you know, there is no confusion in this question. The probable cause in this case is L-captonuria. Alright, all of you know that the homogenetic acid is getting accumulated, it will pass out in the urine. On getting exposed to the air, it gets oxidized to the black colored pigment. So that is the childhood black urine syndrome. Once the urine is passed, it is clear, but when it gets exposed to the air, then it becomes oxidized and it acquires the black color. So we say blackening of urine on standing. Okay, this is blackening of urine on standing. This is also known as the childhood black urine syndrome. In case of newborns, you will have the complaint of the black diapers. As the children will grow and they start using the washroom, in that case, the frank black coloration of urine can be seen if it is allowed to stand for a few minutes. Okay, in this context, I'll quickly run through the different disorders associated with the phenylalanine tyrosine metabolism. Very frequently, we get the questions from there. You should at least know the name of the enzyme which is deficient in the different conditions without going into details of each of the conditions. So, you know, phenylalanine gets converted to tyrosine by the action of enzyme phenylalanine hydroxylase. If there is deficiency of phenylalanine hydroxylase, we get the classical type of the phenylketonuria. This reaction also requires the cofactor, the tetrahydrobiopterin, getting converted to dihydrobiopterin, which is recycled using the various enzymes, one of them being the dihydropteridine reductase. If there is a problem in the coenzyme part, then also the conversion of phenylalanine tyrosine will get affected, and again you get the phenylketonuria. This is called the malignant type. Nowadays, this is PKU type 1 and this is PKU type 2, type 3, type 4 and type 5, because 4 different enzymes are required in the biosynthesis and recycling of the tetrahydropeptide. Depending on which enzymes are involved, you can have the type 2, 3, 4 and 5. Tyrosine is then converted into the hydroxyphenylpyruvate by the enzyme tyrosine aminotransferase. The deficiency of this enzyme will give rise to the tyrosinemia type 2, also known as the Richner-Hanhart syndrome. This is known as Richner-Hanhart syndrome, sometimes also known as oculocutaneous tyrosinemia. This is also known as the oculocutaneous tyrosinemia. The hydroxyphenylpyruvate is converted into homogentisate. The enzyme required here is the hydroxyphenylpyruvate oxidase. Now here you have two things. If the enzyme is deficient, if the enzyme is decreased in amount, in that case you get the neonatal tyrosinemia, also known as tyrosinemia type 3. Mostly it is asymptomatic, very mild mental retardation may be there in these patients, but most of the patients will be asymptomatic. On the other hand, if the enzyme is defective, see, it is not deficient. In this case, we are saying that enzyme is not working properly. Enzyme is there. Synthesis is taking place, but there is some problem in the enzyme. It is not able to work properly. In that case, we get the condition known as Hawkinsinuria. An intermediate product is which is called Hawkinsin passes out in the urine, therefore condition is called Hawkinsinuria. In Hawkinsinuria, you get the characteristic chlorine-like odor in the urine, or swimming pool water odor in the urine is seen. These patients again will be mostly asymptomatic. In some patients, there can be the failure to thrive due to the metabolic acidosis due to Hawkinsin. Moving on, the homogentisate is converted to fumarate acetate by the homogentisate oxidase. If the deficiency of this enzyme is there, then the condition that we just discussed, alkaptonuria, will be there, where we have the blackening of urine on standing. Lastly, fumarate acetate converted into fumarate and acetate by the fumarate acetate hydrolase. Deficiency causes tyrosinemia type 1, also known as a tyrosinosis or hepatorenal tyrosinemia. Hepatorenal tyrosinemia or the tyrosinosis. Okay, in these cases, what you find that the renal stones of tyrosine may be there. The boiled cabbage odor of the urine may also be there. About PKU, all of you know that mousy or musty odor of the urine is characteristic founding in the PKU. In the tyrosinemias and the PKU, mental retardation is a common feature. Severity depends on the different types of tyrosinemia. Tyrosinemia type 1 has significant mental retardation similar to PKU. In tyrosinemia type 2, it will be moderate. In type 3, mostly it is absent. Only few patients will present with mild mental retardation. Moving on to next question. A child presents with difficulty in vision. On examination, cherry red spot were seen on macula. Now, when we talk about cherry red spot, immediately in your mind, the condition which should come is sphingolipidosis. There was no organomegaly, very important presentation. There is no organomegaly, identify the disease. So, I said cherry red spot, immediately in your mind, the condition which should come is sphingolipidosis. So, Hunter's is out. Among the sphingolipidosis, in Gaucher's and in Fabry's, the cherry red spot will not be there. So Gaucher's and Fabry's is also out. Now coming to Tay-Sachs and Niemann-Pick. In Niemann-Pick, you find significant organomegaly. So your answer becomes a Tay-Sachs because it is specifically mentioned that organomegaly is not there. So in this case, your answer will be the Tay-Sachs disease. Please be familiar with the different enzymes for the different sphingolipidosis. Very, very important. The most important among these being the Gaucher's, the Tay-Sachs, the Niemann-Pick, and the Fabry's. Fabry's because it is an exception. There is no mental retardation. There is no cherry red spot in these patients. So because of that, the Fabry's is one which you should know. Gaucher's you should know because it is the most common lysosomal storage disorder, right? It is the most common lysosomal storage disorder. Tay-Sachs we just told you because it is slightly different from the others. Organomegaly is not there. So the Tay-Sachs. And Niemann-Pick because this is the only condition where the sphingomyelin will accumulate. In all other conditions, the glycolipid will accumulate, right? But this is the only condition where the sphingomyelin will accumulate. So you should remember the names of the enzyme for these 4 conditions. Moving on to next question, a child presented with refractory anemia. The father gives history of bone pain. The smear of bone marrow biopsy of the child is provided below. The probable enzyme deficiency is. So if you look at this particular cell, this is having the appearance of crumpled, also described as wrinkled tissue paper appearance. Can you appreciate this? The crumpled or wrinkled tissue paper appearance, which is a Gaucher cell. So obviously you are looking at the beta glucocerebrosidase deficiency. We just mentioned beta glucosidase or the glucocerebrosidase deficiency, which is characteristic of the Gauchers. Okay, so Gaucher cell will be seen in Gaucher disease, or it may even be seen in the chronic myelogenous leukemia. It can be seen in chronic myelogenous leukemia. Okay, but the feature of bone pain, okay, the acute abdominal crisis and bone crisis is seen in these patients. That will help you distinguish from the CML. In CML, typically we don't have the bone pain. The anemia and the Gaucher cell might be there, where we have the pseudo Gaucher cell. It doesn't have the same content. The content is different, but the appearance is similar. Question number 17, respiratory distress syndrome is caused due to deficiency of, I'm sure all of you know this, the deficiency in this case is due to the lecithin. All right, so lecithin, also known as the phosphatidylcholine. Okay, so that is the respiratory distress syndrome. Typically it will be seen in the premature infants. Why? Because the synthesis of the lecithin will take place after the 34 weeks of life. Significant production occurs only after that. So if the premature infant is there, the synthesis of the surfactant, this lecithin is the surfactant, has not yet started in significant amount, and the alveoli will tend to collapse. The surface tension will be lower and they will tend to collapse. We have another question on RDS talking about the changes in the surface tension, which I have not covered here because it will be covered in physiology section, which was talking about again the respiratory distress syndrome only. Question number 18, when there is low insulin glucagon ratio, which of the following is seen in adipocyte? So please understand, when we say low insulin glucagon ratio, means there is low insulin. When there is low insulin, means we are talking about either the fasting or the starvation, right? We are talking about fasting or the starvation state. Now, insulin has a very important role. It inhibits the hormone sensitive lipase. It is an inhibitor of hormone sensitive lipase, right? And it is an activator of lipoprotein lipase. So if the insulin is low, activation of lipoprotein lipase cannot take place. But when the insulin becomes lower, the inhibition of hormone sensitive lipase is lost and it becomes activated. Obviously, when the fasting or starvation state is there, the fat deposition is not going to take place, and the HMG-CoA reductase, which is again responsible for cholesterol synthesis, is not going to be activated in the fasting or the starvation state. Okay, dephosphorylation is causing the activation of the HMG-CoA reductase. So again, this is not going to take place in case of fasting or starvation. So your answer is activation of hormone sensitive lipase. Hormone sensitive lipase is normally inhibited by the insulin. So when insulin levels will fall, this inhibition will be removed and the hormone sensitive lipase will start acting. It will mobilize the fatty acid from the adipocyte. It acts on the stored triglycerol in the adipocyte. Free fatty acid will come into circulation, go to the liver. It can be repackaged in the VLDL, or it can be converted into the ketone bodies in the liver, so that gradually the ketone body level will start rising in fasting and starvation and act as a fuel for other tissues, particularly for brain. Why? Because free fatty acid cannot cross the blood-brain barrier, but the ketone bodies can cross the blood-brain barrier. Going to the next question, a chronic alcoholic. See, the question already tells you chronic alcoholic who is a known case of the gouty arthritis presents with another acute attack of gout. Which of the following is expected in this patient? Okay, so now that we know that alcoholic patient is there, in alcoholic patients you will have the lactic acidosis, right? You will have the lactic acidosis, and because the gouty attack has been there, obviously the uric acid or the urate crystals will be elevated, which is given in the first option. Okay, in alcoholic patients, the NADH to NAD ratio is high. It is not low. Why? Because the alcohol metabolism generates large amount of NADH. The lactate part is elevated, but not urea. It is the uric acid which is elevated. Increased alkaline phosphatase, no. What you will see is increased gamma glutamyl transpeptidase. In alcoholic patients, the GGT level is elevated, not the alkaline phosphatase. So the correct answer is high lactate and the high urate. Moving to next question, a patient presents with pain in knee joint. See, similar question is there. Okay, serum uric acid level is normal. So when you think about knee joint, one of the thoughts comes, okay, maybe the long-standing gout is there, and now the larger joints are also getting affected. But the question clearly says serum uric acid is normal. Synovial fluid shows presence of WBC. When it says WBC, in that case, you have to think about the inflammation and infection. Okay, WBC, you have to think about inflammation and infection. If they would have given the picture of crystals, okay, then we could have thought about the pseudo gout. Calcium pyrophosphate crystal picture, if it was given, then we would have thought about the pseudo gout. Okay, and if the whole joint was clear, then we would have thought about the reactive arthritis. No crystals, no urate crystals, no calcium pyrophosphate crystals, no WBC. In that case, we would have thought about the reactive arthritis. But in this case, it says that the WBC are present. Then we have to think about the inflammation and infection, that is the septic arthritis. Question 21. Patient of gout was treated with uric acid synthesis inhibitor. Possible drug could be. So this is an overlap pharma, and the options are probenecid, allopurinol, uricase, and colchicine. I'm sure you know the answer in this case is allopurinol acts on the xanthine oxidase. It is an suicidal inhibitor of the xanthine oxidase. One of the metabolites, the alloxanthine or the oxypurinol, which is formed, will bind at the active site covalently and permanently inactivates the enzyme xanthine oxidase. Please note the metabolite coming from allopurinol is known as alloxanthine, also known as oxypurinol, which causes suicidal inhibition. This is a type of irreversible inhibition. Okay, this is a type of irreversible inhibition of the enzyme xanthine oxidase. Probenecid is a type of NSAID. It prevents the inflammation. Uricase will cause the further breakdown of uric acid. Uric acid to allantoin. This is what will be achieved by the uricase. Colchicine is the mitosis inhibitor, and it also decreases the inflammation. It decreases the inflammation. It also prevents the migration of the inflammatory cells. It prevents the diapetesis, so that the immune response cells will not reach at the point of deposition of the uric acid, and it also decreases the immune response by preventing the mitosis. So colchicine has an entirely different role, mechanism of action. Okay, neuroletharism is due to which of the following toxins? I discussed this previously when we had the question on osteoletharism. Obviously, you know the answer here is beta-oxalyl amino. So that is the BOA and homoarginine. We had said these are responsible for the neuroletharism. BAPN, we already said it is responsible for the osteoletharism, and sanguinarine, we said, is responsible for the epidemic dropsy. So these are all the questions that were asked in the exam. You can see all the applied questions are there. There is no straight one-liner, non-applied question. All of them are related to the clinical presentation of the patient, and this is how now the papers are going to come, whether it is the INICT or the supposedly next exam that we're going to face. They'll have the questions like this only, where we have clinical question, but you can answer it with the help of the knowledge of biochemistry. These 22 questions can purely be answered by the knowledge of biochemistry. You don't need to know the, I will say, the associated, or you can say the other subject which is involved in this particular scenario. Okay, again, I'll re-emphasize main focus on vitamins. After that, the second most important topic would be the inborn errors of metabolism, whether it is for the glycogen, or it is for the amino acids, or it is for the lipids. We have seen all the inborn errors have been covered. Okay, and after that, subsequently, the clinical aspect of the metabolism of the different molecules has been asked, whether it is alcohol, whether it is the uric acid, all of that has been discussed. So I hope this discussion will help you in understanding which are the important topics for exam. You are also able to quickly cross check your answers that you gave and your knowledge, and you can gear up for the INICET if you're preparing for that, just 2 months away. So it will help you in your preparation for INICET also. Thank you very much, and stay tuned. Keep watching. Log in for success.